So, we have some visceral structure which are present on the neck, right. So, the structures on the neck can be divided of two parts which are before vertebra and post to vertebra. So, if it is the vertebra that this particular segment has, anterior to that we have some structures which are like soft tissue structures, and we have some muscles present in the neck region. Now, there in the neck region we have some muscles, we call them as front of the neck muscles, which are present in the front region. There are some muscles that are present on the back side, we call them as back of the neck muscles. So, the back of the neck muscles and the front of the neck muscle constitutes and have some functional difference. Now, we have this particular organ which are present to this particular region. So, we have a windpipe which are called as trachea, which is having a non-collapsible structure. Now, posterior to the trachea we have a collapsed lumen structure which we call them as the esophagus. Now, in between trachea and esophagus we have a groove, we call them as tracheoesophageal grooves, which is occupied by this particular vagus recurrent branch of vagus, we call them as recurrent laryngeal nerves. Now, side to it we have this particular neurovascular structures, we call them as carotid sheaths and its content. Anterior to it we have this content, we call them as strap muscles. Now, out of this, the strap muscles are of importance. What importance it has is covers the front of the neck and covers the content which is present in front of the neck region, viscera, blood vessels and important neurovascular structures. Now, this particular strap muscles is called as strap muscles because they look like ribbons or flat. Now, these particular strap muscles being thin, they have a coverall integrity which is they are covering. Now, these particular strap muscles, once they contract, they make an important contribution. So, contractions of the strap muscles makes something, we call them as movement of larynx. Now, the larynx has a organ and viscera has a cartilaginous part and as well as has some bones which are making this. We call them as cartilage, which are paired cartilage and unpaired cartilage of this particular larynx. Now, whenever we are swallowing this particular larynx, this larynx moves up. Now, there is a group of muscle which is pulling up the muscles larynx up and there is a group of muscle which is pulling it down. So, the muscles which are known as strap muscles which are coming from this particular front of the neck region, from this particular thorax region going to this larynx, they are contracting and pulling this particular trachea down when this particular trachea in a position which is higher up. So, this movement of the trachea is jacked up by the muscles which is known as suprahyoid muscle. We have this muscle suprahyoid, that means above the hyoid bone. We have this particular muscle which is present in this above region, suprahyoid group muscle, and the infrahyoid group muscles which are known as this particular strap muscle that is pulling this particular larynx down. Now, this particular suprahyoid muscle which is moving this particular larynx out, which starts with this particular mylohyoid, omohyoid, etc., etc., has an important contributions. What important contributions? Whenever we are swallowing, the food material is coming from the mouth and going through the windpipe or the junctions of the oropharynx. Now, over here, junctions of the oropharynx, we have two tubes present. One is anterior tube, other is posterior tube. Now, this particular anterior and posterior tube is so placed, there are every chances of aspirations or dropping the foreign body maybe to the anterior part or maybe on the posterior part. There is a 50-50 chance. Now, this particular 50-50 chance is nullified by this upward movement of the larynx. This particular upward movement of the larynx helps this particular larynx to move up whenever we are swallowing. So, with this particular swallowing movement, the larynx moves up and take the shelter under this cartilage, we call them as epiglottis. So, this particular larynx as it moves up, which is pulled by this particular suprahyoid muscles, which is pulling this particular larynx up and taking the shelter or the umbrella of the epiglottis, and this particular larynx moves up. so that this particular opening of the larynx and as well as the windpipe, which is known as trachea, is guarded or shielded. So this food material is going down to this particular other opening, which is known as esophageal opening. So this movement of this particular strap muscles is to jack it down or pull the thing down when this particular swallowing part is over. So if it is moved up by the suprahyoid muscle, the infrahyoid or strap muscle pulls this particular trachea down, larynx down as we have finished the swallowing part. Unless this particular thing pulls down, this particular larynx is kind of like in an upward position, so that we cannot just like take this particular larynx to a normal positions down unless until we have this particular strap muscles. So these strap muscles have got like a importance in terms of short notes. That's the functions that you have to understand in terms of swallowing reflex or deglutition. Suprahyoid what is doing out here, infrahyoid what is doing. Other than this, the strap muscles, as it is covering this particular structures of the viscera, they have a stabilization effect whenever we are talking. So if we are talking, this larynx, if it is shaking, which is happening because of the vocal cords are vibrating, so that vibrations will lead to the shaking of this particular larynx. If the larynx is shaking, then the voice will be breaking. So that particular larynx need to be stabilized externally, so that your voice remains as it is whenever this particular vocal movements are going on. So it is stabilizing this particular larynx whenever we are talking or any kind of voice productions is going on. These are the two things which is happening. Other than these strap muscles are doing that covering of the structures of the viscera, namely the muscles which are covering out here is a gland which is present in here. We call them as thyroid gland. So this particular thyroid gland is present in this particular region. We call them as muscular triangle of the neck, so which is covered by the strap muscles. Now these particular strap muscles has to be cut to remove this particular thyroid gland if it is diseased. So this particular strap muscles which is covering in here, we have to know the anatomy of it whenever we are dealing with the surgery which is related to the thyroid or parathyroid or this particular organ which is present in. This is one thing that you have to understand related to the thyroid surgery. Other thing that which happens over here, on deep to the thyroid, we have this particular trachea which is lying in here. Now this particular trachea is the windpipe. Now sometimes what happens out here, we may have an acute obstructions of the windpipe. Namely, we have, say for example, we have a edema or a kind of like anaphylaxis or kind of shock which leads to the mucosal swelling and blocking this URT, upper respiratory tract. Now what is upper respiratory tract? That is conveying the air from the mouth or nose to this particular lower down segment which is known as the lower respiratory tract. Lower respiratory tract, that means we are going to deal with the lungs and the vicinity. Now air comes from the upper respiratory tract to the lower respiratory tract. By any chance, if you have an obstructions in the upper respiratory tract which may be acute, sudden obstructions, maybe somebody have swollen some kind of food material or any kind of foreign bodies that have blocked this particular opening where this particular air is getting in, or may have some sort of edema. Say for example, a person is allergic to some foods, say for example seafoods, and that particular allergic seafood has created a huge acute edema. We call them as anaphylaxis or a kind of severe variety of reactions which is known as hypersensitivity. Now that particular anaphylaxis creates an edema which is acute inside this particular upper respiratory tract and blocking the air passage. Now if that air passage is acutely blocked, we need to create emergency for emergency purpose and bypass airway tracts. We do this particular, catch up this particular trachea at this particular muscular triangle, splitting through this particular strap muscles. So we call this particular surgery or the procedure as tracheostomy, and as it is going on this particular emergency purpose, we call them as emergency tracheostomy. So this particular tracheostomy, that means we have to slit this trachea to create a bypass tract. So there are two ways of doing this tracheostomy. One is planned tracheostomy. That means whenever you are creating a kind of slow growing mass. Say for example, a person has a cancer in the mouth and it is growing big and gradually it is obstructing the airway. It is happening over time, slowly. Now, a situation that may have developed acutely, that is what I am saying, anaphylaxis. So both of the occasions we have to create a bypass tract through the trachea. We call them as emergency tracheostomy or tracheostomy. So if you are going to deal with this tracheostomy, which is an emergency, we basically deal with few things. So I am doing a schematic diagram. On top we have a hyoid bone, HY, then we have this particular thyroid cartilage, and then we have this particular cricoid. So these are the three sets of the bones which is present in above down on this larynx or the voice box, and they are separated and joined by these membranes, etc., etc. Now between this particular cricoid and thyroid we have a membrane, we call them as cricothyroid membrane. Now this particular cricothyroid membrane is avascular, that means it do not have any blood vessels. It do not have any blood vessels. So this particular cricothyroid membrane is easy to identify. How we are going to identify? We identify this particular bone. Its trachea is the middle portions. What is this trachea over here? It is Adam's apple or laryngeal prominence. If you roll your finger down, then next nodular prominence we find it this particular bone. So we mark with the lower, with the skin marker pen, with the lower limit of the thyroid cartilage with the finger palpation, and we mark this upper border of cricoid, and we mark with this particular tissue which having a diameter of 10 millimeter in millimeters. We mark it and press an opening exactly in the midline. We create an emergency tract for saving an emergency procedure, just like emergency procedure which is happening in case of anaphylaxis. Straight in the midline, cutting through this particular membrane. What membrane? Cricothyroid membrane. So this is a lifesaver conditions that we usually do. Now in this particular process, if you just remain to be in the midline, we basically runs between this particular strap muscles, pierce the skin and pretracheal fascia and pierce this particular region and go inside this particular region which is the cavity of the larynx, and we can put a kind of like a pipe which is maybe a thin as a refill, empty refill, that can also serve a purpose. Or if you get some kind of like a tracheostomy tube or narrow tube, we can place it and create a bypass airway tract. The patient cannot breathe through mouth, cannot breathe through nose, can breathe through this hole which is present in the trachea, and through the trachea air can still reach to the lung. So this procedure we call them as emergency tracheostomy. Involves in this particular triangle we call them as strap muscle triangle, also known as the muscular triangle. Now this particular anatomy of this particular region matters to us in terms of doing this particular emergency procedure, identifying this particular 1, 2, 3 cartilages, and then finding a slit gap between this cricothyroid membrane and it's exactly in the midline. If you make a hole on an emergency basis with no procedure, no anesthesia, nothing, you can save the patient's life. Later on you can buy some time, do and further elaboration of the surgery. This is one kind of things. Other kind of we call them as planned tracheostomy. That means you are going to deal with a slow growing tumor, cancer growing slowly obstructing. You cannot operate in a positions like that. If you operate it, it's going to be a more difficult situations, so that you are not going for a surgical removal of the tumor. Rather, to alleviate the pain of this particular person which is going through, we create a bypass tract. That particular bypass tract involving the splitting of the trachea. That means after this cricoid cartilage, we have the beginning of the trachea. Trachea, we have the tracheal rings. We count the tracheal rings below this particular cricoid, 1, 2, 3, 4 like this, we can count it. And once you count that, is second and third preferred over or fourth between tracheal ring. Once you have count that, we make a hole over this particular region. And that's going on through planned procedure, operations, OT, anesthesia, proper procedures. We cut a hole in here, take this particular chunk of the tissue over here and make it as a D-shaped opening or make a C-shaped opening and put a tube inside and press this particular tube and create a permanent airway tract. That means again we are creating a bypass tract. Again we are working on this particular region in front of the neck involving the strap muscles. So for that we have to know about this particular strap muscles anatomy. Again for this particular procedure we call them as planned tracheostomy. So there are two varieties of intubations. So one is known as emergency tracheostomy or emergency intubation, or planned tracheostomy or planned intubation. That means you are putting some tube inside intubation to the respiratory tract, and both of the occasions you have to deal with this anatomy of this strap muscles region in the front of the neck with this particular anatomy of the larynx and anatomy of this particular cricoid, thyroid and hyoid cartilages. Clear? So this procedure matters to us whenever you are dealing with this particular front of the sides about the clinical problems or clinical situations over here. This emergency tracheostomy is a lifesaver. You cannot do effort to have much time. Maybe you have 2-3 minutes to buy time to save this particular patient, because this is so acute, happens so huge and so acutely. We do not have the time to bring the patient to hospital or bring it to like in a procedural room or go through history, checkup, etc. etc. Not possible. So we do this particular on the spot, right way, any blind object through this particular cricothyroid membrane, also known as cricothyrotomy, which is piercing this membrane. What membrane lies over here? Cricothyroid membrane. We pierce in the midline, avascular. For that reason, no or minimum bleeding is there, and we forget about the bleeding because we are going to save some patient's life by doing this particular procedure. We are not bothered about bleeding. Only thing that matters over here, we have to be strict in the midline. Why we cannot sway from the midline? Why we cannot move away from the midline? Because side of the midline we have these large vessels, carotid vessels, right? So we understand this anatomy of being this large vessels which is present. That's why we have to be strictly on the midline, right on that particular point, make a dot and just like a pierce it over there. If you just like move like this, then you will be hitting somewhere here or there and ruin the process. All right. So this particular involvement of the strap muscles, which is kind of important and lifesaver procedure that we must understand. Second thing about this particular region, we have the carotid blood vessels. So sometimes if you have an accidental injury over this particular neck region, this carotid blood vessels maybe have some kind of injuries or ruptures or some kind of trauma to it. A bleeding of the carotid artery, which is going to supply to this particular blood supply to the brain, is going to supply blood to this particular head, neck, face regions, need to be stopped on an emergency basis. So this carotid artery bleeding can be stopped by pressing on some vertebral transverse process. You see that this particular carotid artery placed on the lateral side. Now this particular carotid artery which is present on here, if it is bleeding, you have to press externally from anterior to posterior, right? Now if you are pressing on anterior to posterior, you are going to press on this particular transverse process of this particular vertebra, cervical vertebra, on this particular blood vessel or carotid artery which is present in here. So you have to press it so that this things comes over here and pressed and compressed on this bony landmark. So pressing over here in this region. We have this particular C6 cervical vertebra transverse process which is really large and has a nodule. We call them as carotid tubercle. So that particular carotid tubercle which is present on the transverse process of C6 vertebra, on which if you press, we can stop the bleeding which is coming from the carotid artery. Now, how we are going to find this particular C6 carotid cervical vertebra? Now, it is easy to find if you understand this particular anatomy of this, define this cervical vertebra. Now, the cervical vertebra, we have how many of them? 1, 2, 3, 4, 5, 7. So, 7 cervical vertebra has a sharpest and tallest and broadest spinous process, which is present if you bend your neck, which you can see the bump inside this particular on the neck region, the largest bump which is C7. So spinous process of the C7 you can identify. So if you identify C7, if you move up next to it, you can identify easily C6. Now if you identify the C6, then you roll back and reach to this side of the neck, you can easily corroborate to that particular C6 cervical vertebral transverse process. And if you identify that region, if you press on this particular carotid artery which is present on the side of this region and press over there, you can achieve hemostasis which is coming from bleeder which is coming from the carotid arteries. So, what artery you are pressing on? Carotid artery have got branches. We call them as CCA, common carotid artery, which splits into ECA and ICA. So, that particular split happens at the level of the superior lamina of the thyroid cartilage, which is way higher up. So, basically by pressing on the C6 cervical transverse process, you are closing this common carotid artery, which basically stopping the blood from external carotid and internal carotid. Now, if you are pressing both of them, it is going to lose the blood from the both sides. So, brain is not having blood. So, in case of the bilateral injury to the carotid, we cannot have any chances. Anyway, patient is going to die. If it is unilateral, then we have a chance by pressing on this common carotid artery over the transverse process of the C6 vertebra, pressing on, trying to achieve hemostasis. You press high enough, you can just like get it. And again, this is lateral in position. If you are pressing on midline, basically you are choking the windpipe. So, anyway, without helping, you are basically choking the patient to die. So, you have to understand where you are pressing and what you are pressing. So, which positions you are pressing for tracheostomy or emergency tracheostomy, and which positions you are pressing on achieving, that is called this bleeder which is coming from the carotid artery, that anatomical landmark matters. So, you have to identify the exact spots whenever you are dealing with this particular same phenomenon or same problem. This is related to this particular problem. Other thing about the carotid artery, right side CCA and CCA of the left side. Now, carotid artery is an important landmark artery which can be picked up for measuring pulse. Just like you pick up this particular pulse from this arteries which is known as radial artery. The anesthetist during this surgery picks this particular pulse commonly from this particular carotid artery. It is easier for them because they stand on the head side of the patients for doing this particular intubations or any kind of assistance to the patients. Now, this particular common carotid artery at the bifurcation point which is present has a important element. We call them as carotid body and carotid sinus. Aortic body, aortic sinus which is present on the arch of aorta, carotid body, carotid sinus which is present at the bifurcation point of the internal carotid side. Now, this particular point which is known as carotid body, carotid sinus, which are baroreceptor, chemoreceptor, perhaps you have seen that in a physiology. Now, this particular baroreceptor which is present in this region controls the blood flow which is going through internal carotid artery and which is highly sensitive. So, in some of the patient, this particular or individual, this particular carotid sinus which is present at the split point of the common carotid artery at the internal carotid artery side is sensitive or hypersensitive. We call them as sick sinus or carotid hypersensitive. So, on those individuals, if you touch this particular carotid, there is a hypersensitivity which blocks this particular arteries, blood flow, and blood going to the brain, it stops and patient faints. It recovers momentarily afterwards, but it happens. So, we call them as this kind of carotid hypersensitivity, keeping on mind whenever you are taking this carotid artery pulse. In physiology examinations, you probably asked to demonstrate how to take this particular carotid artery pulsation, or if not, they will teach you, or in a higher grades, they will be going to teach you. Now, this particular carotid artery, if you are pressing on, you have to keep in mind, always ask the patient to be in seated positions or lying down. Never take this particular carotid pulse in a standing posture, because you don't know which person is sensitive to carotid sensations or not. So, if this particular carotid sinus is sensitive in some individual, and if you trust this, there may be carotid hypersensitivity and blocks the blood flow to the brain and patient faints. And the moment patient faints, that means patient gonna collapse and create a catastrophe. So, whenever you are taking this carotid artery pulsation, you have to ask the patient to be seated so that you have some support, or take it in a lying down positions whenever you are taking it. This is one thing. Second thing is that whenever you are picking this carotid artery pulsation, always take carotid pulse from the one side. because he leave this carotid artery of the other side to flow the blood to the brain. So this particular blood to the brain is not completely stopped if you are pressing on the carotid artery. So the rule number 1, you are asking the patient be in sitting positions, be in lying down positions for carotid artery pulsation check. Second thing, you are not going to check this particular carotid artery pulse both at the same time. So explain why a patient while checking this particular carotid pulse faints. Explain why carotid artery of the both side pulsations is not taking simultaneously. Understand the reasons? So this particular explain why kind of questions are important. Rather, you are going to practice this in your life for these particular carotid artery pulsations, picking up sensations, and you will be doing are important in the front of the neck region. Second thing or last thing about this particular regions. Now we have this particular 3 layers of deep fascia in the neck. We call them as investing layer, we call them as pretracheal and prevertebral. Now they are basically a single layer or having 3 lamina split into 3 different planes. Pre-investing layer is most anterior, then we have pretracheal, and then we have the prevertebral layer. Now this particular prevertebral layer which has a continuation downside. So from the vertebra it is going down, and going down, as it is crossing down, it's fanning out towards the axilla, and in axilla it is wrapping around this particular axillary blood vessels, making a sheath. We call them as axillary sheath. That axillary sheath holds this particular nerve, artery, or that means branch of the brachial plexus which is present in it, and as well as the brachial artery, as well as this particular vein which is present on it. So it is wrapping on. So these particular expansions or downward continuations of the prevertebral layer is going down till this particular layer, we call them as axillary sheath. Now this axillary sheath ends on the floor of this particular axilla. So if you remember this axilla, we have this particular axilla that looks like this, and this particular anterior wall, posterior wall, lateral wall, medial wall, floor, and the roof. So this particular floor of axilla which has a hollow tight into the skin, this particular layer which blends with this layer of this particular floor or deep fascia of the floor of the axilla. So this is continued from the neck region and going down to this region. Now what importance out here is that if you have something which is happening in this particular vertebral level in the cervical lesion. So for example, vertebral infections of the vertebra, we call them as osteomyelitis. That means infections of these bones of the cervical vertebra. Now commonly we have a bacterial infections which is happening here is known as the tuberculosis. Now this tuberculosis infections creates some kind of pus. That particular pus starting from here may trickle down through this particular plane of this prevertebral layer and can reach up to the axilla. So infection of this particular vertebra starting to happen in the cervical or the neck region vertebra, and the pus rather than settling down on this particular neck region, it has trickled down to the axilla. Why? Because of the gravity, it is dropping down. Moreover, it has a fascial plane. Through the fascia, it is going down. So the infections of the neck can reach to the axilla. Explain how and why. So this can be explained by these extensions of the prevertebral layer of this sheath which is present in the neck region, which is continuous with the cervical sheath. Cervical sheath is nothing but a covering which is wrapping around this particular content of the axilla, which is including this particular brachial plexus, which includes the axillary artery, axillary vein, and ends into or blends with this particular skin of or deep fascia of the axillary floor. So infection from the neck can trickle down through this particular region of coming from the vertebral infection and settle down to the infections. Same thing can happen above here on this particular on top of clavicle. That also can happen because they have same continuations. So it can settle down into these particular pockets which is known as supraclavicular fossa. It can trickle further down, can reach to the axilla. The same thing happens in case of the tumor, in case of this particular infections on the lumbar region. If you have a tumor, If you have an infections in the lumbar vertebra, tubercular infections, which has a continuations of the deep fascia from this particular lumbar fascia to lumbosacral fascia to this particular region, which can reach to the psoas fascia, and trickling down on the same thing, it can reach to the front of the groin. We call them as psoas abscess. We have seen the psoas muscle, psoas major, psoas minor, which is present in the posterior abdominal wall, so which is anchored to the L3, L4, L5, the transverse process from where it is coming, which is wrapped around by the fascia, which is known as psoas fascia. Now, psoas fascia is a continuation or layer of the lumbosacral fascia. So, lumbar fascia, which is continuous with the psoas fascia, and as it is, infection is coming on the vertebra, it is going down from the vertebra to trickling down with the gravity through the psoas plane and reaching to the psoas muscle attachment point. Where the psoas muscle is attached, we have this iliopsoas attached on this particular hip femur. Remember the femur have got greater trochanter, lesser trochanter. The lesser trochanter have an attachment of the iliopsoas muscle. So, it can reach to the groin region and settle down as a swelling, all known as abscess. So, explain why kind of question. Infections from the neck can reach to the axilla, can reach to the supraclavicular fossa. Infections from this particular lumbar region can reach to the groin through the psoas fascia, which is blending with the lumbar fascia or iliolumbar fascia, which has got 3 layers, 3 laminas.